you have a fascinating couple of speakers, so I'm not going to speak for too long, but just to welcome you, how good it is to see so many people. I don't think you came in from the cold, because it's not exactly warm here, and we might need to stand up and wriggle around a bit, but I think you'll be so captivated by our speakers that you won't even notice that it's a wintry day, albeit a very nice one. We're going to invite both our speakers to speak to you for a short while, for about 15 minutes. They're both in a slight degree of shock because they're so used to having PowerPoints and slides that they realize that they're on their own with the sheer force of their personality, their knowledge and their wisdom to keep you informed and interested and even entertained. Louise Meincke is going to speak first, and then Sarah Hawkes will speak, and then I hope, I'm sure, there will be plenty of time for discussion and conversation and debate. So first of all, it's a real pleasure to introduce Louise, who I know as a very dynamic and feisty Head of Policy and Public Affairs for World Cancer Research Fund International. And the world of global health really needs people with passion, with knowledge, with information, with evidence. And Louise has certainly brought that to the world of cancer, which is a really challenging world. Some of the statistics about the impact for people with cancer in some of the poorest parts of the world are really shocking. Louise has also worked for other organizations, with Consortium for Street Children. She's worked at Amnesty International, in the Houses of Parliament, and in the UN Office of the High Commissioner for Human Rights. Louise holds a master's degree in human rights from Sussex University, and she's an elected fellow of the Royal Society of Arts. So Louise, really looking forward to hearing you kick us off and get us off to a really interesting start. Over to you. I don't think you have. Yeah, I think so. I think it's up to you.
Do I stand with this? This one? Do I use this one?
Sorry, my mistake.
Okay, I'm glad we got that sorted. Thank you for that really nice introduction, Christine. And thank you everyone for being here tonight. I mean, it's a real pleasure to have been invited to speak to you in such a amazing historical building and on an issue that is so topical at this point in time. And it is topical and extremely important because at the moment, we're living in a world where we're seeing an increasing cancer burden worldwide. There's an estimated 18 million cancer cases around the world in 2018. And this is alongside exponentially rising rates of other non-communicable diseases such as diabetes, stroke, and heart disease. So the organization I work for, World Cancer Research Fund, estimates that 40% of these cancers could be prevented. And just think about that for a moment. 40%, that's nearly half of all the cases in the world which could be prevented. And it means that nearly half of all the unnecessary pain and suffering in this world due to NCDs could be prevented. I think this is extraordinary. It also has huge economic and societal costs, of course, and not to mention the individual cost. And I think we all know someone who's been affected by it, or maybe ourselves have been directly affected by cancer or some form of NCD. So it's an issue that's close to my own heart, and I think it most likely will also be an issue that's close to your own heart, just because by the very nature of it, we are all affected by this. So just to put it into the context of the UK, if 40% of cancers in the UK were prevented, that's the same as 144,000 cases a year in the UK alone. It's a staggering number of people. So NCDs are now the biggest killer worldwide, accounting for 63% of deaths, and 80% of all these deaths occur in low and middle income countries. And studies also show that the NCD burden is more negatively affecting people of lower socioeconomic status. So what's actually happened here? Because we live in a world where our environments are encouraging a sedentary behavior and a lifestyle and eating unhealthy food and drink. And this is what we call a Western lifestyle. It's not necessarily a word I like to use, but we generally call this a Western lifestyle. So as we're moving towards a Western lifestyle, as we've transitioned into a Western lifestyle, our health have suffered equivalently. And developing countries in Latin America, Africa, and Asia are also seeing an exponential rise of NCDs, overtaking hunger as the main killer. So this is nonsensical. Think about that we're living in a world where people die not because they have too little food, but because they have too much of the wrong food. So when I was given the brief to talk about inequality in the health of nations, I was thinking, well, there's so many areas that we can touch upon in this. But I've chosen to focus on 3 main questions in the 15 minutes that I've got. I tried to think of some fancy headline for all of this, but I just couldn't. So I'm going to just say it really simply that firstly, I'm going to look at what I believe the role of government is in this area. Secondly, what is the role of industry? And finally, what is the role of human rights? So firstly, what is the role of government? So World Cancer Research Fund is a leading expert on the prevention and survival of cancer through diet, weight, and physical activity. And we do this by providing independent scientific analysis, and we translate these scientific findings into concrete policy recommendations for governments, as well as informing the public of how to reduce their cancer risk. Our latest cancer prevention report has found that being physically active decreases your risk of 3 common cancers, while being overweight or obese increases your risk of 12 common cancers. And this is 5 more common cancers than the evidence showed 10 years ago. Our report was an outcome of a detailed independent analysis of worldwide research over the past decades, and it has provided us with concrete recommendations which we can give to individuals and societies of how to reduce their cancer. The report can be found online, and you can also request a copy of the summary for free. So yesterday morning, I was reading an article about the history of our humble chair. And I thought it was fascinating that there are no mentions of chairs in the Bible. There are no mention of chairs in the 30 Lions of Homer. There are no mentions of chairs in Shakespeare's Hamlet. So while we all take a moment to actually look down, I think we can all accept and we must realize that we are all more or less guilty of preferring, or probably more likely to have been wired into a preference of moving less and eating more. And on the context of this, I usually say when I go to these sort of events, please take this opportunity to actually stand up on the sides. You don't need to sit down in the chair to listen to me speak. In fact, you might actually be able to absorb more of what I'm saying if you're standing up. So there is absolutely no need for you to sit if you don't want to. But it's interesting, isn't it? Because it's hard. It's hard to get people up and out of the chair in terms of what we've got used to. And when I first started working specifically in global health, I was absolutely amazed at going to meetings at the UN and government level, talking about the importance and the benefit of healthy living, while everyone was sitting down for hours and eating crappy food in the breaks. Go figure. But this brings me to the question of what is the role of government? Because although we can encourage and we can support individual behavior change, and this is very important, I believe we can only achieve real lasting change through government action. And many argue, especially in today's world, that we don't want to live in a nanny state. But government have a crucial role and a responsibility to promote, protect, and fulfill the rights of their citizens to the highest attainable standard of health. We must move from a focus on blaming the individual to enacting systemic change. Because blaming the individual, it seeps through every creak and cranny in our media and in our government policies. Being overweight or obese carries huge stigma, while what a person can afford to buy and where they live has a negative influence on their health and is usually outside of their immediate control. So government must develop and implement evidence-informed policies that promote healthy environments. This is, for example, through regulating how food and drinks are marketed to children, ensuring that urban planning favors cycling, promote breastfeeding, or putting in place a tax on sugary drinks. This would enable people to make healthy choices. So without a PowerPoint, it's quite hard to describe this, but at World Cancer Research Fund, we've developed something that we call the Nourishing Framework. It's a policy framework which basically sets out a comprehensive package of policies that we believe governments should implement to promote healthy diets and prevent overweight and obesity. Each of the letters in Nourishing stands for a particular policy area. So for example, U stands for use economic tools to address food affordability, while R stands for restricting food advertising. The database has an accompanying, the framework, is accompanied by a database which holds 515 implemented government actions in 130 countries. I've got more information about this, including a leaflet, to describe a little bit more detail about what Nourishing is and how it's used, and is a resource that is free of charge. What Nourishing shows us is that while some governments, are working to regulate and incentivize to create healthy environments to a lesser or greater degree, often this approach is not comprehensive, which means that governments often enact policies in a particular area and then the impact is not as they intended. Or often, government enact policies which are subject to a very short political cycle, and most crucially as well, industry interference. So this leads me to the second question of what is the role of industry. Big business puts profit before health. And the world's largest producers of unhealthy food and drinks are relentlessly pushing their products which are high in sugar, salt, and fat, and they're always looking to expand to new and emerging markets, in particular in those markets where government regulation is low. These so-called commercial determinants of health play a large part in the rising burden of NCDs, while the private sector argues that poor lifestyle choices of the individual are to blame. These big food and drink companies have been found actively trying to discredit independent scientific analysis, spends millions of dollars in lobbying activities to influence governments and pursue legal challenges. And should all else fail, we also have examples of them engaging in good old-fashioned bullying and intimidation. What we see is essentially that the tactics employed by the tobacco industry are having a renaissance with the big food and drinks industry. So as an example, some of you may have heard about this, but very recently over the summer, the governor of California enacted a law which prohibited the implementation of any further sugar taxes in that area until 2030. And this comes as many different cities, including Berkeley, has implemented these levies and have shown that they are working to reduce consumption of sugary drinks. And interestingly, what was found was that the implementation of the law came after a dinner that had been held between the governor and the American Beverage Association, PepsiCo, and Coca-Cola. This is not democracy. So World Cancer Research Fund recently published a report looking at lessons learned from around the world in implementing sugar taxes. Sugar taxes are gaining momentum. There are 47 jurisdictions around the world right now that have implemented such a tax, including in the UK, and often against impressive industry opposition. Sugar taxes work. They work by driving down consumption of unhealthy drinks, which leads to weight gain. And studies in Mexico have found that in particular sugar taxes are driving down consumption among people of lower socioeconomic status who often bear the brunt of the NCD crisis. Industry arguments against sugar taxes include such taxes are regressive because they hurt the poorest the most, as they are the main consumers of such drinks. Again, it is down to individual responsibility to not drink too many sugary drinks, which leads to weight gain. It is discriminatory because it is only levied on a particular product and not all products. And even that it is a breach of the company's right, their right to sell products to consumers in a free market. So interestingly, what we see is that industry is employing the rights language in order to undermine global health and democracy. They're using it in their legal cases against government. But I would argue that global health, or the lack of global health, is strongly linked to entrenched issues of inequality and discrimination, both within and between nations, which leads me to my third question. What is the role of human rights? Human rights are about addressing issues of inequality and discrimination. And it struck me when I first started working in global health, coming from a human rights background, that there were very few actually talking or even making the link between global health and human rights. And as I've said, it's interesting because we've seen that industry utilizing the rights-based language. So thankfully, this is slowly changing. There are several UN experts that have published reports looking at the promotion and consumption of unhealthy commodities, global health and human rights. And the World Health Organization and the Office of the High Commissioner for Human Rights now have a working group on maternal and child health. Civil society organizations are increasingly recognizing that human rights offer a framework for holding governments to account, and they're using it to develop campaigns which bring the voices of people affected by NCDs to the table, as well as developing advocacy and policy tools to assess whether governments are actually doing what they should be doing, which was protecting people's health. So when you're employing a human rights approach to global health, it means that governments must, in essence, protect, promote, and fulfill the rights of their citizens to the highest attainable standard of health, including by regulating industry and implementing policies which promote healthy environments. Governments must support the right to health by allocating appropriate resources, and this means both in terms of capacity, in terms of knowledge, and also in financial terms. And government must ensure that all programs and policies prioritize the needs of those furthest behind, without discrimination and with meaningful participation. So human rights provides a set of clear principles for setting and evaluating health policy and programs by targeting discriminatory practices and unjust power relations that are the heart of inequitable health outcomes within and between nations. But finally, we all have a role to play. This issue is much bigger than any one of us individually. So whatever your profession, I know that there's a bit of a mixed bag in here today, but whatever your profession, whatever your skills, whatever your passion, whatever your background, we all have a role to play in this space to promote global health. So what I'm going to do is, in order to show you what this actually feels and looks like in practice, and in the interest of reducing sedentary behavior, I would like you all to stand up. Which is challenging, I know. Everyone's thinking, oh God, I was just so comfortable. Why do I want to stand up? So what I'd like you to do is just put your hands in the air. And then on your right hand, point to one finger. And then start tapping. Not much of a noise, is it? Let's try with 2. And then come up with 3. And a little bit louder, we're going to do 4, 5, and then you're going to clap. And this is actually what it feels like when people get together rather than doing work individually. Thank you. And thank you for standing up and playing along.
Louise, thank you. I thought you'd probably get us all almost dancing. I was wondering whether I should give people the opportunity to stand up, but you've brilliantly done it for us. So I'm sure you've stimulated lots of ideas, lots of questions, and also, hopefully, given people information that's shocked them and will spur them to want to see things differently. Our second speaker, I met for the first time this evening, but when I read her background and her areas of interest, I felt I should have met her a long while ago. So I'm really delighted to introduce to you Professor Sarah Hawkes, who is by background a sociologist and an epidemiologist, as well as a medical director. She's Professor of Global Public Health at University College London, where she leads a research team looking at the use of evidence in policy processes, and particularly in relation to gender and health and sexual health. She's now heading up a new Centre for Gender and Global Health, and Sarah's had a great deal of experience living and working in Asia, where some of these issues are particularly strong, and she'll tell you, I'm sure, much about them. She's worked closely with governments, with civil society organisations, with researchers, as well as with the World Health Organization and UNFPA in Asia and in the Middle East. So we're really delighted to have Professor Hawkes here this evening to talk to us on the issues from her background and experience. Thank you.
Thank you very much, Christine. And as has already been said, there's a slight air of nervousness here when we were told that there were no PowerPoints, because for those of us that give talks regularly, the idea of taking the PowerPoints away is like, it's like losing part of your being. That how can I possibly talk without a PowerPoint? And now I'm even more nervous because I feel like Louise has actually given the talk that I was going to give you anyway. So I'll just stand here and give you a few ideas about perhaps different ways that we, as a collective community of people, might start thinking about health and health inequalities and health inequities. And so, as Christine said, I do work as an academic, so I'm afraid I am going to have to take a really academic start to my talk and focus on definitions. And for those of you that have ever gone through anything relating to tertiary education, you'll know that as academics, we're completely obsessed with the notion of definitions, because unless we all know what we're talking about, then generally we get to the end of an evening like this and find that we've all been talking about completely different things. And I could come back to that as far as gender is concerned later. But I'll start by a definition of health. And so as a world community, we agreed on a global definition of health in the late 1940s. And it's health that's not just about the absence of disease. It's not just about us not being sick or not feeling very well or not needing to go to the doctor. It's about a total state of social, emotional, and physical well-being. And I think the part of that people tend to forget is the social well-being. Because since that definition came into force in 1948, what's become really evident in terms of the quantitative, the empirical evidence that people like me can play around with and can write talks and even make PowerPoint slides about, is that it's the social well-being of communities and nations and people that is really the driver of people's health outcomes. So, of course, all of us are born with some kind of genetic potential, some kind of biological potential about what our health is going to look like over our entire lifetime. And we currently live in a state where kind of what you're born with is what you get, and you're going to just have to make the most of it biologically and genetically. The idea that we might be able to manipulate our biological potential is not as far off as some of us would like to perhaps think it is, but it's not what we're talking about in the health systems and health sector right now. But that biological potential, that genetic potential, is determined, is acted upon by the lives that we then lead. So if you look at the central line, which goes very close to here, I think, doesn't it? We're pretty close to this. In fact, we're on the central line, aren't we? There is approximately a 25-year life expectancy gap between the end of the central line and the middle of the central line around Kensington, Notting Hill. So if you're right out in the East End of the central line, your life expectancy is going to be about 25 years lower than by the time you reach the sort of Bond Street part, or the little bit further west of the central line. That's not genetics, really. That's the social environment in which all of us find ourselves living. And it's that social, commercial, economic, political, cultural environment that actually determines people's life chances as far as their chance for a healthy, productive life is concerned. And so in global health, what we're concerned with isn't just the numbers of the distribution of who gets sick and who doesn't, but it's about the power differentials that people have in their ability, as Louise said, to realize the right to a healthy life that, like our genetic potential, is the right that each and every one of us as human beings on this planet is born with, because we all come with the same set of human rights, but our ability to realize those rights is dependent upon the social, economic, political systems in which we live. So to me, the first challenge for all of us, if we're thinking about health inequalities and health inequities, and perhaps I should go back to being an academic and think about what's the difference between an inequality and an equity. None of us are ever going to have the same absolutely equal health. People are born with different genetic problems. They're born with different genetic expectations, as I mentioned, as far as their health is concerned. So the ability of all of us to reach an equal health status is not what we're talking about in health differences. What we are talking about is ensuring that societies meet the differential needs of people according to the health status that they have. That means addressing inequities. That means ensuring that each and every one of us has that equal opportunity to live as healthy a life as is possible for us as an individual, is about addressing inequities. So once we've understood that what we're addressing is social, economic, commercial, political inequities, because that's where the burden of major determinants of health outcomes comes from, we start thinking about health in a really different way. Last week marked the 40th anniversary of the Declaration of Alma Ata. It shows you how long ago it was, because Alma Ata has changed its name. It's now Almaty, the capital of... God, I'm having a brain freeze. Tajikistan. Is it Tajikistan? Thank you. Thank you. The reason I was confused was because the meeting was then held in Astana, which is the capital of Kazakhstan. Okay, so we've... Right, so we've moved from Alma Ata to Almaty to Astana. And what we have lost along the way, apart from keeping a load of A's in all of these declarations, is a notion that health is about the social world in which we all live. So 40 years ago, the nations of the world, led particularly by what was called the non-aligned movement. In other words, the countries that we might class as developing countries, non-industrialized countries, in the language of the time, third world countries, pushed for a global meeting to ensure that health was a right and an achievable goal for every single person on the planet. And if you look at the Declaration of Alma Ata that came out 40 years ago from that meeting, what it committed all of the nations of the earth to do was to address those social determinants, as well as focusing on building up health systems, i.e. clinics, hospitals, primary healthcare centres in each and every country. What we've seen over the ensuing 40 years is the discourse drift almost inexorably towards people equating health with, can I get to see a doctor? So when people think about what does it mean to be healthy and have the right to health, what people generally tend to start talking about is, do I have the right to go and see a doctor? Is there a nurse available for me when I want to see one? What the evidence shows is that at a population level, health systems can never contribute more than about 20% to overall population health levels. In other words, what makes populations of people sick and ill and unhealthy is the environment in which we all live. And we've known that in this particular part of London since the 17th century. The foundation of the academic degree that I have a PhD in, epidemiology, which is the study of the distribution of health in populations, the founding father of epidemiology was a man called John Graunt, who in the 17th century took the birth and death records, presumably of this church and all of the other churches in the City of London, and started to study who lives and who dies, and what's the distribution of who lives and who dies. And he then compared that to Hampshire. And lo and behold, he found some differences that exist to this day. And those differences were that men live shorter lives than women, and that people living in rural areas tend to live better lives, longer lives, healthier lives than people living in what he called the stench of the city. And he meant this very place we're sitting now, not this church. I'm not suggesting there was a stench emanating from in the 17th century from here, but from the surrounding area. And he encouraged us all to think that what we needed to look at was the social environment. But from Alma Ata to Astana, the meeting that was held this past week, what we've completely lost is the ability to see that when we start talking about the need to improve health and to reduce people's inequalities in health, whether that's between nations or within nations, whether that's from the east end of the Central Line to Bond Street, how do you reduce that 25-year life expectancy gap? That what we need to do is start thinking about reducing social inequalities and political inequalities and addressing the things that really make us sick, which over the past 40 years, as Louise has very eloquently shown you, is the rise of the consumption of unhealthy products that people are making profits from. The biggest killers globally in the world are no longer the kinds of things that John Graunt was recording in the 17th century, or even I was recording 25 years ago when I spent 4 years living in a village in rural Bangladesh. People in low and middle income countries are not dying of infectious diseases at the rates that they were doing even 15 years ago. The biggest killers in the world today are the non-communicable diseases, as Louise has mentioned. The things that we eat, the air that we breathe, the unhealthy products that we consume, particularly tobacco and alcohol. In other words, the things that people are making profits from. So the biggest challenges to us, if we want to start reducing inequalities in health globally, nationally, or even within the city that we all live and work in, is to start changing the discourse, to start changing the conversations that we're having about what actually makes people sick or healthy and what actually leads to people having the right to a healthy life expectancy. And that, as Louise said, involves all of us coming together, because the history of global health shows that where we see major changes in the way people's address health and disease problems doesn't come from when we expect governments to do something for us. Of course, we need government regulation, as Louise has mentioned, but the big changes, the big revolutions in global health come when communities start demanding the things that they have a right to. So when we think back to the HIV epidemics of the early 1980s and the 1990s. It wasn't that Big Pharma suddenly woke up one morning and thought, gosh, it's really important that everybody in the world who's infected with HIV has exactly the same right to antiretroviral therapy as everybody else. They didn't suddenly think our $15,000 a year treatment costs might not be an equitable or sustainable cost for the entire globe. What happened was that communities of people living with HIV got together and chained themselves to the White House railings and invaded the Centre for Disease Control and blocked the car parks of Big Pharma, and they made change happen. So yes, we definitely need political will, something that's particularly lacking as far as social enterprises like global health are concerned right now, today. But we also need communities to come together, in other words, all of us, and demand that we have the right, not just to health services, but the right to live in environments that promote health for each and every one of us. Thank you.
Well, I promised you an interesting start to the evening. Now it's your opportunity to ask questions, raise the debate. Do you agree that the food industry is mainly responsible for the ill health that we see, the inequities we see? Nobody's talked very much about that. So though Louise had us moving all around, the cars, the things that have stopped us being as physically active as generations earlier were. So that's been a big change in our life as well. Times we sit in front of computers rather than walking around giving messages and going and knocking on doors are again, I think, part of the changes that have not encouraged the healthiest of behaviours. So do my two speakers have questions for each other, or are you waiting to hear and receive the comments and questions from the audience? Right, and there's certainly somebody right in the front. Please, if you feel like it, say who you are.
Yeah, okay, great.
Press on it.
So, hi, my name is Alexander Rie, I'm a journalism major. So you emphasize the importance of government action as well, a good environment, but you didn't that much talk about prevention. So I wanted to have your thoughts about it, how prevention is important to tackle the issues about health, and would you say that it's easier like to deal with prevention rather than tackling inequalities themselves?
That's a really interesting question. Certainly my organisation is very much about prevention by focusing on those risk factors that Louise talked about. So prevention or government action? Who's going to?
It is a good question, and I would almost throw it back and say that I think that tackling inequalities is in and of itself prevention. That I think, as I tried to say, health systems, health services, going to see the doctor at an individual level, expanded to a population level, can only really improve 20% of overall population health levels. It's addressing the inequalities in what are called the social structural determinants. That is the prevention. In other words, it's addressing the inequalities, the economic inequalities, the gender inequalities, education, geographical inequalities that every society has that leads to reductions in health differences, health inequities. So in other words, that's a prevention agenda.
So let's see if I can get this. Oh, it's working. That's exciting. I'm not just wearing this to look good. So in my presentation, and specifically what I work on, is very much that government action is linked to prevention. So you have to have government action to prevent and control and reduce NCDs. But there's often a focus on the control and the reduction and the management of NCDs rather than the actual prevention. So what I'm responsible for in my department and the organization is to put that focus on the type of policy actions that governments can take and should take and must take to encourage the prevention of NCDs. So, like I say, health is so much more than, when you talk about government action, so much more than the Department of Health. Okay? So if you want to really prevent NCDs, you can't just talk to the Department of Health. You also have to include the Department of Education. You have to include the Department of Work and Pensions. You have to include maybe even the Department of International Development. But most importantly, and if we're talking about taxes or levies or financial incentives, you have to include the Department of Finance. You know, none of this is actually going to come through without the, the specific endorsement by the Ministry of Finance to include any kind of government policies that promote and promote healthy diets and reduce sedentary behavior. So it's what we call a whole of government approach to tackling global health inequities and inequalities.
Great question. Next question, please. I think you need a microphone. You need to speak quite loudly into the microphone. I forgot to.
Thank you. I have two questions.
Good.
Number one, when you spoke about sugar-sweetened beverage taxes, was that specifically to high-income countries or low-income countries as well? And if it's for low-income countries, how would issues surrounding sugar-sweetened beverage taxes adjust to the fact that a lot of times in lower income countries, sugar-sweetened beverages are actually cheaper than water? So in terms of the tax being regressive might be true in those contexts. And secondly, do you think that, or do you see a role for public-private partnerships in this conversation around addressing the social issues and social determinants in global health?
Two really good questions. I'm sure you can both answer them both, but I think Louise particularly probably would like to take the one about sugar-sweetened beverages. And I have to say, I think the only time in my life I've drunk 7-Up was in a low-income country. So it's not just sometimes price, but also safety. Yeah. Makes it quite a challenging issue. And I haven't been to India for a while, but you could never get Diet Coke in most low-income countries, whereas obviously you can here. And then Sarah, I think, has particular expertise in public-private partnerships, so that will be, but feel free to answer them both, but Louise, kick off with the...
So thank you for the question. It's really important, because a lot of the time we have these policies and we live in high-income countries, and then there's a tendency to promote these policies as if they would also just be relevant and applicable, or even able to be implemented in a completely different context, both regulatory, socioeconomic, cultural, and so on. But the report that we did, so I've got a few copies of it with me here today, so it's this one called Building Momentum. This report looked at sugar taxes around the world. And yes, there has been momentum in high-income countries, probably because there's a lot of different elements that we look at in the report that has to come together in what we call the perfect storm to actually create the momentum around developing and implementing a sugar tax. And probably often these elements are more readily available in high-income countries, such as a strong civil society and a regulatory environment and so on. But that said, there are a lot of countries in the Pacific, small island states of the Pacific, that have implemented sugar taxes because they have, I can't remember the actual percentage now, but it's more than half of their adult population in some of these tiny Pacific island countries or island states that are obese. So they have a massive, massive issue. So it isn't just in high-income countries, although I appreciate it, but it is also low-income or low and middle-income countries that are now implementing sugar taxes. In the report, we set out different types of taxes as well to show different ways that a tax can be implemented depending on the national context. So that's all in the report with case studies as well. But there is something that's interesting, like you say, with sugar drinks being either cheaper and more safe than water in a lot of these countries. So, for example, in Mexico, where this is a huge problem, what they did with the tax was that they actually said that the income from the tax would be used to create water fountains in schools. And what they've also found is that by increasing the price of sugary drinks, that then water, by not changing price, naturally became cheaper than sugary drinks. I have a little bit of an issue with this, in as much as it's hard because of the sustainability agenda. If we start promoting people buying bottled water instead of sugary drinks, we're just creating another problem again. So I'm not saying that this is a panacea. I don't sit here and have the answer to it, but I know that it's a problem. I know it's an issue, and I don't feel comfortable by sort of saying buy bottled water instead of sugary drinks, because there's a lot of other issues around that, including sustainability. But earmarking could be a way of, earmarking like for water fountains in school could be a way of utilizing a tax.
Sarah, public-private partnerships and their role.
Yeah, sure. I'm going to address the sugar-sweetened beverages as well, though, because in fact we've got a study underway across South Asia, Southeast Asia, and the Middle East that's looking at both government and industry responses to the notion of sugar-sweetened beverages, taxation on sugary drinks. And one of the constant, well, there's a couple of things that are kind of interesting in terms of how do you move forward with a government tax. And one is that it depends on who bears the cost of that tax. So in a number of countries, industry has talked about not actually passing that tax on to the consumer in order to continue to maintain consumer demand. So in other words, industry absorbs the cost of the tax because that makes a marginal difference to their profit. What we have heard, however, from industries based predominantly in low-income countries is that, and this is industries that are making sugary drinks and salty snack foods and high-fat foods, is that what they respond to isn't so much government regulation as consumer demand. And when you have a consumer population, the reason you can't find Diet 7-Up is because there isn't yet a consumer demand for it. Is the answer coming from industry? So I would say it's really important from a health perspective, exactly as has been said, that we don't spend all of our time just talking to ourselves, telling each other how bad health is and how bad industry is, but we actually have to understand the perspectives of industry too. And that has, for us in many countries where we're doing these in-depth analyses, has thrown up really interesting perspectives that, for example, and I'm going to give you a real example, that when we talked about reformulation of salty snacks, crisps, that sort of thing, chips, in one country in South Asia, the company that was responsible for the biggest market share said that they would never reformulate alone, because otherwise what they would see would be a market created for crisp smuggling from India. So this was Bangladesh saying, we're never going to do this by ourselves. This needs to be a global reformulation. You know, everybody needs to agree to reduce salt in their crisps, because otherwise you will simply create cross-border demand and you will see crisp smuggling, which, you know, sounds a little bit hilarious. But from the history of tobacco smuggling across borders, where you have differences in taxation, for example, we know that it's a real outcome of when you make these minor changes, what seem like minor changes to taste or price, is that you create cross-border demands. And so it can't be single countries doing things just by themselves, is the message that we're getting from industry, which I think then leads to your second question of public-private partnerships. So yes, this is something we've looked in detail at a global level, not at individual country public-private partnerships, of which there are many. I mean, there's lots of examples in this country, for example. As far as we looked at public-private partnerships in depth in relation to sugar, salt, and trans fats, and we were unable to find a single example globally of where this had been a working model. That, in other words, if what you want to do is reduce population exposure to sugar, salt, and eliminate unhealthy trans fats, that has to be government regulation. There is there are two countries where industry has voluntarily reduced salt, and that's the UK and Finland. But it's not proving to be totally sustainable. There's a lot of fluctuation in what industry is doing with salt levels. So in other words, you know, that's the closest we've got to industry doing something voluntarily. But public-private partnerships generally, globally, they're interested in product development and product supply. We couldn't find examples of public-private partnerships that are focused on changing the way industry operates.
Probably time for one more question. Please.
To what extent do you think issues of class have influence on inequality, whether it be global or not? And I know that's a ginormous theme, but I am intrigued and interested in relation to what you've been saying tonight.
Sorry.
Shall I say it again?
Yeah. Just the last bit.
I'm interested in to what extent you think class influences inequality, whether it be between nations or within nations. And what I was saying at the end was, I know that that's a huge theme, but in relation to what you were both saying, it seems to me there has to be some relevance. And I know Uncle Carl had a lot to say about many things, but maybe there's some relevance to this too.
So I think, to me, it almost comes back to to the starting point of definitions. And when we talk about definitions, when we talk about inequalities, people hear different things depending on their worldview, if you like. So a lot of the time in the circles that I move in and go to conferences in, when I say the word inequality, people think about the difference in life chances between men and women, because they hear gender as the predominant divide. I personally like to do most of my work looking at the intersection of different inequalities. So you can't, from the kinds of work that we do, it's very difficult to say that one of these social determinants is somehow over and above everything else, that it's the intersection of class and gender and ethnicity and urban location and which country you're living in that really affects your life chances. It's not just one single thing. So I can do a gender analysis and show you the differences between men and women, but at the end of the day, what matters as well is the intersecting inequalities. So it's about poor men and rich women. What are their life chances as opposed to poor men versus poor women? So in other words, it's about making us aware that there's no single magic lever that we can pull that says if we get rid of class inequalities, it's all going to be better. That's a part of the story, but it's about that intersection between all of these inequalities to which every society is exposed and is suffering from.
Louise.
I'm not sure I really can add much more to that. I think it was summed up perfectly. But it is interesting when, talking about class, but even looking at, international development and, like you say, the difference between, and I don't even like these words, but I'm just, developing and developed countries, etc., and how that actually influences outcomes. And we know that there are these huge structural inequalities between countries. And if I'm at the UN, I see it, in great detail, but also how different countries are actually using their muscle power. And I'm perhaps now talking about a particular country in particular under the auspices of Mr. Trump, who at the moment is very much bullying other nations when they try to develop strategies and reach consensus on global health. And it's unfortunately the world we live in, which is why I was calling for sort of everyone here to take some responsibility and action in whatever way that is possible to you. Because if we all just stand by and watch, there's that famous quote, isn't there, we could end on. Bad things happen when good people just stand by and watch. And I think that's very much the case in the space of global health at the moment.
We're very nearly, yes, come on, jump in. You need a microphone. If not, you might need to run up here and speak from here.
To put health in all sectors agenda, and when there is a very clear conflict of interest, and also that politics are made in short term instead of long term?
That's a really big one, but
This is a big one to end on. Just to say, from our perspective, what we're really pushing is to try and provide the evidence to governments, to policymakers that are independent, but also show what we call the pathway of effects. So by saying, what you're saying with the short cycles of politics and conflict of interest and so on, is to show that if you, for example, implement a sugar tax, you're not necessarily going to see reduction in overweight and obesity rates within the first 5 years, maybe even 10 years, but there will be other pathways of effects by which you can see if you are moving towards that end goal. So that for us is something that we're very much looking at and promoting and pushing to show that, yes, if you want to reduce overweight, obesity, promote healthy diets, etc., you can't just expect this to happen, in the next 5 years. And also it means that I think especially as civil society, we have to keep the conversation going and not rest on our laurels. So if now there is a sugar tax in the UK, it's not about resting on our laurels and sort of expecting that to continue if another government come in place, but to continue the conversation with all different political parties, all different stakeholders, and build on that to make sure that that pathway of effect is continuously highlighted. I don't know if that answered the question. Your
And
question was really big. But
I was going to say, I mean, it's almost the million-dollar question that I think we've all been struggling with, and certainly has been struggled with in global health since Alma Ata. So the quest for health in all policies really started in 1978, when immediately after Alma Ata, when it was realized that the health sector alone can't make us all healthy. So I would almost throw it back and say, we need some new ideas. That, you know, this is about how do we get people to take health seriously. You know, health is generally taken seriously at a global level when you show an economic impact of an unhealthy population. For those of us that come from a rights-based framework, we would say that's not sufficient, because what if you can't show an economic impact? Or what if people's lives are suddenly deemed to not be worth that much? Then you've lost your argument. So how you embed this in the way societies see themselves as what does it mean to be developed, I think is something that in the 30 years I've been in global health, we haven't been able to deal with. So I think it's for your generation to now come along and say, you've been doing it wrong all this time. We need new ideas. We need new ways of approaching this question, because it's fundamental to the sustainability of all of us as healthy people and healthy planet.
That's a great way to end a really interesting discussion, and I think that everybody here has really heard the message that health is much more than healthcare and hospitals and doctors and nurses. It's about what we eat, it's about how we move around, and it's about how much we poison ourselves or are poisoned by smoking, alcohol, and air pollution. And with those thoughts in your different lives, in your different countries, what are the new and different things that could make a difference? Well, I'm sure you've got more ideas than when you arrived, thanks to our two excellent speakers. And so thank you to them, and thank you for you.